Welcome, everyone. Thank you for joining us. We are waiting as more people enter the room, and we're going to give it another minute or two for people to get settled before we start with introductions. Thank you, everyone. We appreciate you joining us this morning. We still have people getting let into the room and getting settled. We're going to give it another minute or so before we get started. We still have a regular stream of people coming in from the waiting room, so we're still going to give another minute. Thank you, everyone, for giving us your time this morning. We're excited to have Dr. Wehbi moderating this really wonderful roundtable. Okay, I think we've gone a few seconds without a new addition to the room, so let's go ahead and get started. Thank you again for everyone who's joining us. We really appreciate you taking time to attend our public health seminar here at NDSU, and also this is the last in our series where we're celebrating our 10th anniversary as a program. Our title today is The Role of Public Health in Our Lives Now and in the Future, and this will be moderated by Dr. Nizar Wehbi. He is North Dakota State Health Officer. Prior to his appointment, Dr. Wehbi served as Deputy Director of the Center for Health Policy and was an assistant professor at the University of Nebraska Medical Center in Omaha. As the Center for Health Policy's Deputy Director, Dr. Wehbi conducted research and policy analysis to inform policymaking with a focus on improving population health and the efficiency and effectiveness of the U.S. healthcare system. In that role, he led initiatives to address binge drinking and colorectal cancer and conducted analysis on the healthcare workforce shortage. As an assistant professor in the College of Public Health at UNMC, Dr. Wehbi directed the Masters in Health Administration program, MHA, with teaching areas of focus that included health administration, health policy, U.S. healthcare system, and human resources management. He also co-led a university-wide faculty leadership program. And as we go, please feel free to enter any questions that you have for our panelists into the chat box. And Dr. Wehbi, I will turn it over to you.
Yeah, thank you, Ramona. Good morning, everyone, and welcome to our seminar or panel discussion, I would call it. We have really a great panel this morning, and I'll go through introducing our panelists. And as Ramona mentioned, then our participants can add their questions if they have any questions in the chat. So with us this morning is Dr. Alicia Belay. Dr. Belay is the Assistant Director of the Community Engagement Unit at North Dakota Department of Health and Human Services. She works closely with the HIV and the STI programs and helps lead work around women's preventative health, including improving prenatal and postpartum care for women of lower income and for minority populations. She works most closely with indigenous and new American, foreign-born, and immigrant communities in North Dakota. Dr. Belay has a PhD in social and health psychology and a master's degree in public health from Gondar University in Ethiopia. She has worked in the area of health equity for over 15 years. We also have Dr. Paul Carson. He is an infectious disease physician for over 25 years and has that clinical experience for over 25 years. He cares for patients with complicated infectious diseases. Prior to joining NDSU in 2013, he held roles at Sanford Health, including chair of the Department of Infectious Diseases, director of clinical research, and chief quality officer. He is currently professor in the UND School of Medicine and Health Sciences and a professor of practice in the North Dakota State University Department of Public Health, where he founded services as the medical director for the Center for Immunization, Research, and Education. We all know it as CIRI. So welcome. Our third panelist is Dr. Terry Dwelle. Dr. Dwelle has over 40 years of clinical and public health experience in the United States, Eastern Europe, Latin and South America, as well as Central and East Africa. He directed the Medical Ambassadors International East African Community Engagement Program for 8 years and was the North Dakota State Health Officer for 16 years. And that was the record for being a state health officer. He has also worked with the University of North Dakota School of Medicine, the CDC, or the Center for Disease Control and Prevention, as well as the Indian Health Service. Dr. Dwelle currently serves as the President and Educational Director of the North Dakota Public Health Training Network. Our fourth panelist is Dr. Andrea Eustace Zausel. She is an associate professor in the Department of Public Health. Her research focuses on aging, injury prevention, and gender-based health issues. Specific areas of interest also include impacts of the COVID-19 pandemic on educator health and well-being, and on the health and well-being of older adults. Other points of interest include aging, injury prevention, and menstruation management, and period poverty for adolescent females. She received her PhD in gerontology from NDSU. Dr. Mary Larson has earned a PhD in teaching and learning research methodologies from the University of North Dakota, a Master of Public Health from University of Minnesota, as well as an undergraduate majors in nutrition, biology, and health and fitness. She has worked to promote health for the past 33 years in various settings, including women, infant, and children, migrant health, higher education settings, and in primary care as a lifestyle medicine provider, registered dietitian, certified diabetes educator, and certified health education specialist. In 2013, Dr. Larson was hired at NDSU to provide leadership for the health promotion specialization for the Master of Public Health program. Dr. Larson is an associate professor in the Department of Public Health, where she teaches public health leadership, policy, systems, and environmental health promotion, and applied community health sciences courses. She conducts research in areas under the broad umbrella of health promotion and disease prevention. She maintains an active record of university, community, and professional service. Our sixth panelist is Renee Mock. Renee is the Public Health Director for Bismarck-Burley Public Health. In this role, Renee directs the delivery of comprehensive public health programs and services for the city of Bismarck and Burley County. Renee has worked in healthcare administration for both public and private sectors for more than 20 years. She is board certified in medical practice management and a fellow of the American College of Medical Practice Executives, which is the highest level of distinction in the medical practice management profession. She earned a Bachelor of Science degree in Business Administration with a minor in Business Communication and an MBA in Healthcare Administration from the University of Mary in Bismarck, North Dakota. So as you see, we have great expertise, great panelists. So welcome to our panelists, and probably we'll move into some questions. And we start with, we always go and learn about public health, but each and every one of us has their own notion and their own definition of public health. So I would like to kind of go around the panelists and see what your perception or definition of public health as you perceive it yourself. And maybe we'll go by the opposite order of introduction. So maybe we'll start with Renee.
Sure. Thank you, Dr. Wehbi, for the question. I think in local public health, that's who I'm representing today. We really are advocates for health and wellness and speaking up for those that are maybe unable to speak up for themselves when it comes to access to health care, advocacy for them, and really looking out for the health and wellness of vulnerable populations. And so that has been a lot of our work at the local level.
Sure. And Dr. Larson?
Yeah, thank you. Absolutely. And just to build on what Renee said, I would start with public health is about creating conditions that makes flourishing not only possible, but unavoidable for all. And so when I think about this and I teach in this area, the conditions that we're talking about include everything from the physical built natural environments, which might include sectors like housing or employment or green spaces or sustainable food and water systems. And I also think about economic environment, so living wages, things that impact a person's ability to care for themselves and their family. And then the mental, psychological, social environments where all people are really feeling like they belong and they matter, regardless of race, ethnicity, creed, sexual identity, age, educational attainment, and region.
Great, thanks. How about Dr. Yusuf Soso?
Yeah, so I agree with everything that Renee and Mary have just stated. I think I'm going to take a Star Trek stance on this, though. We are all on this planet, and whether we want to be on this planet or not, we are all on this planet. So my thought is public health is doing everything in our power to ensure that everyone on this planet can live happy, healthy lives, whatever that takes. So I'm going to take the Star Trek stance.
Okay. I like that kind of we are stuck on this planet, I think, for now. So Dr. Dwelle, how do you kind of see public health through kind of, your long experience in public health practice?
Yeah, Nizar, and thanks once again for leading this panel. As I thinking about this, it seems like from my perspective, public health, and I think it's been touched on by the other panelists already, but is a special set of skills and competencies that help individuals and communities to achieve a state of holistic health, similar to what Mary had said, dealing with all of those social determinants of health and wellness. And it does that by kind of addressing the 10 essential services that were developed in 1994, and also I think some new tools that we have been using in public health, like facilitating integration and community engagement processes. So, you know, it's broad, which is something that was kind of unusual to me as I entered the field of public health. I thought of it as quite kind of narrow, like maybe taking care of water sanitation and things like that. But it's such a broad approach to health and wellness.
Okay, great. Maybe we'll move to Dr. Carson. And I know like you have the academic and practice expertise. So how is that kind of like comes together with public health?
Yeah, so maybe at the risk of maybe being slightly long-winded, for which you can cut me back later, I just would share a little anecdotal story on this for myself, starting off most of my career as a clinician. Sort of at a very basic level, public health is synonymous with population health to me, but I had a bit of an epiphany on this later in my clinical career, where I was on call one weekend seeing a long list of people with very complicated infectious diseases. And I think I was seeing about my 5th consult of a diabetic patient who was at risk of losing their leg from very serious complications from their diabetes, very severe infection. And I was kind of despairing of this. And at the same time, I was starting in my new role as the Chief Quality Officer at Sanford, where we were implementing a number of quality improvement initiatives, policies, interventions to try and improve a number of different things, one of which was diabetes at our whole population level. And we actually were, and that was for a panel of 10 to 15,000 diabetic patients in the Fargo region that had diagnoses of diabetes. And we were it struck me that, you know, those 5 patients or so I was rounding on, we'd failed them. The wheels were sort of set in motion 10 to 20 years before at having failed at preventing their diabetes in the first place, or managing their diabetes adequately to where they were now at risk of losing their leg and oftentimes their kidneys or their eyes. And then seeing some successes at a population level in thousands of patients with our interventions at the population level in Sanford Health really was kind of an epiphany to me. And seeing those changes at a population level were very deeply gratifying, but it takes a different kind of eye, because you have to be able to see numbers and data as your success, as opposed to those direct person-to-person interactions, or as a clinician, what can be very gratifying interpersonal interactions, you now translate to data, but there's faces behind all of those data points. And if you can see that, you realize you're pulling very big levers and turning very big dials that have potentially much greater impact than what you might be able to do at the individual level. And so I get a great deal of satisfaction on trying to work in those types with those types of dials and levers, if you will.
Sure. So we'll move to Dr. Belay, and you work with many kind of like special populations or underserved communities also. So how do you see public health in your lens?
Mm-hmm. A lot of what Renee said, I was just thinking, yep, ditto at the state level. That's what we're doing too. But I think what's interesting, what Dr. Carson shared, I came through a different set of careers. I'm the newest to public health in this group. And I came for almost the opposite reason that Dr. Carson came. So, I remember many, many years ago now, almost 20 years ago, sitting in front of this computer screen, looking at these little brain waves. And I was looking at the electrophysiological signature of attention and all these computers around me. And the ultimate goal was that we were working towards understanding the brain so that we could impact Alzheimer's. And that was really cool, but it was so distal. That outcome was just way out there. And it was really hard to come every day and think like, okay, there's people out there that someday, 20 years down the road, like maybe right now, they're being impacted by that work that I did back then. So for me, I entered this field in public health being really excited that we can be so much closer to the community and see that impact. And for me, when I see that chart at the end of the year that shows that reduction in something, to me, that feels really proximal and really tangible. And then in our role in the community engagement office, we get that particularly exciting opportunity to really work closely with the community and hear their stories of how they've been impacted by our work. So I think that's really what I think about with public health, is having that chance to actually directly impact, and the timeline is more around 5 years rather than that 20, 30 years that I was looking at in my previous role.
Sure. Okay. Any additional thoughts on public health as you kind of like heard from everyone or other panelists? Any additional thoughts or ideas that come to mind?
Well, Nizar, this is Terry Dwelle again. I think that one of the things that, I think is pretty obvious to most of us who've worked in public health is that we are the only unique profession that has a mission of primary prevention. Not saying that the other health professions don't get involved with that. But, as a clinician, as I was trained as a clinician, I was trained to do secondary and tertiary prevention. That was where all my training came from, like Paul was saying. And we are in a unique position to focus on risk factor prevention. And I think that once again comes back to, I think, some of what Alicia was saying, but also I'd mentioned about integrating. We can't do it ourselves in public health to take care of all of those 10 essential services. We have to integrate, we have to collaborate and partner with others to get this job done. But we represent that primary prevention wing, which is our primary mission.
Yeah, very well said, Dr. Dwelle. And that's part of public health, is kind of like we going upstream and doing our interventions upstream. I just want to remind our audience that if you have any additional questions or you want to ask any questions, please type them in the chat and we will get to them towards the end of our session. So I like our panel because it has kind of like the academic group as well as the practice-based group. And probably everyone has heard of something they called COVID that happened over the last 2 to 3 years. In fact, it affected and impacted our lives. Every single person on this planet is affected somehow by COVID. But more specifically, as you are kind of like look at your daily work or the work responsibilities that you do, how do you see this pandemic affecting or impacting the work that you do on a daily basis? And I'll open it so he who has the a ready answer can go first.
Yeah, Nizar, I could probably start, I guess.
Yeah, go ahead.
I think during the pandemic, the impact for me was on a reaffirmation of the power of community-led efforts in dealing with public health issues like COVID-19. And I probably have to give a little bit of a history of what I was doing during that period of time. I was consulting with the Turtle Mountain Band of Chippewa Indians to develop their COVID response, but they also wanted to use that opportunity to build a public health infrastructure, a tribal public health infrastructure. And I remember as that new department was kind of formed, they immediately formed a coalition which included state, local public health, other agencies and organizations at the tribe that met every week to look at the epidemiologic data for Turtle Mountain and make a response and determine the kinds of a collaborative coalition kind of led response. And one of the things that just impressed me so much, and I've shared this with Paul, was we expected, because of the high-risk population, we expected that Native American community would see about 6 to 7 individuals, a death rate of 6 to 7 per 1,000. Well, when we looked at it in September, the death rate at Turtle Mountain was 2.8 per 1,000. In North Dakota, it was 2.9 per 1,000. In the United States, it was 3.1 per 1,000. And that impressed me. That community took charge and controlled it by doing various mitigation measures, encouraging COVID vaccinations. As I mentioned, and Paul and I had talked about this before, the immunization rate, COVID vaccination rate at Turtle Mountain was one of the highest in the state. And so that was a empowered community engagement that just reaffirmed to me how important that is in accomplishing public health at the local level.
Sure, thanks. Maybe we'll, Renee, I see that you got off mute. Please go ahead.
Yes, I have some things to add to that. So I think with the COVID pandemic, people that did not know about public health before know about public health now. And are, unfortunately, there's some negative connotations that go with that. They think that's all we do is COVID response. And so there's a little bit of education and re-education that we have to do to get people informed and educated on what we actually bring to the community. Also, preventive healthcare, I think, was pushed to the wayside throughout the pandemic. And with our focus being on prevention and promotion, we're really working hard to get people back on track with preventive screenings and overall healthcare and wellness. Vaccination rates have reduced, so we're working hard to get people back up to be current on their immunizations. And then just overall, I think public health is, we're susceptible now because we are in the limelight or have been in the limelight to scrutiny. And so me personally, as public health director, as I'm working on planning community projects or community public health programs, I'm taking into consideration the last 3 years of COVID and how that would impact what we're going to do moving forward. And so a lot of additional planning and maybe thought goes into community engagement opportunities. Like Dr. Dwelle had said, we have to kind of think about each of our communities. And that's what's important about local public health is we have that local understanding of what works in our communities and our partners, and every area of the state is different. And so at the local level, we're following the overall protocols that the state health department assigns to us, but we're really focusing in on the community needs and the health needs in our own areas. And so that's been challenging and probably will continue to be.
Sure. Alicia, yeah, please, how has that impacted your work?
Well, I think the example that Dr. Dwelle gave really resonated with me, that collective impact and people coming together across sectors. And of course, we've known that in public health that people have to work across sectors, but I feel like COVID kind of really made that more obvious to everyone else outside of public health. So we saw a lot more collective action. And I think another change I've seen just is kind of in the flow and the pace of work. So I think we've recognized we do need to have more people in every conversation, and everyone's realizing that. So there's more cross-sector discussions, which is great. And we can do that because of our telework environment. We can pull somebody in from the national office. And so there's a lot of those larger discussions, and people are convening groups to talk about how we can collectively work on things, which is great. And I'm super hopeful about that because I think that's the future and how we're going to make an impact. The flip side, though, I think, is that as people have gotten comfortable with, sitting in their sweatpants in their house, or just like being able to quick pop a meeting on someone's calendar, it can sometimes work against some of the work work against some of the strategies that we need to use when we're working with communities. So it's still necessary to, I don't know, I have a friend from Africa that used to say, like, you need to put your hand in the food with someone. So we would share a plate in Ethiopia. So you have to put your hand in the food with someone to really get that connection and hear what they need and be able to act on that. And since we're meeting people where they are, we still have to get out of the house and be in those spaces where people are celebrating a special event in their community and so on, if we want to continue to make that really, really strong impact in those communities.
Sure. Okay. Yeah, I see Paul is getting ready to chime in.
Well, sure. So, I mean, the fact that we were one of the few graduate academic programs in the country with an emphasis on the management of infectious diseases in public health, and a center dedicated to immunization research and education, particularly on vaccine hesitancy, we just got thrust to the very center of the fight against the pandemic, both locally and even nationally. And it just like eclipsed almost all of our other work. During the height of things in 2020 and 2021, we were asked for a lot of help from the state health department, the governor's office, healthcare organizations, the media, the public, to speak, educate, advise, help manage, conduct research on all kinds of aspects of the pandemic. But what I thought was really great about it is it gave this very immediate crystallization for our students about the applicability and the importance of what they were training in and what they were learning. I mean, they saw it like clearly and immediately. It was fodder for discussion in almost every class. And we see on like all the applications, or not all, but a lot of our applications to grad school, like, I was involved in the pandemic with this, or this. I want to learn more. I want to know more. I want to make a difference. I want to be there for the next one. So it really changed our work. It's still one of the main areas or focus of our work now. And I think it really has brought attention to a new generation of future public health experts and workers on just what public health means and what it can do.
Sure. Yeah, so this takes us to kind of like more the academic realm. So maybe Mary and then Andrea kind of like give us how you see that impact in your academic world.
Yeah, I miss sort of being on the front lines in many ways. And so the very first thing that I want to say about this is I became even more acutely aware of my privilege. And I just personally, in terms of how this impacted my work, it was very easy to pivot to all online synchronous classes. It was, pretty easy to pivot and do all of my work from my home. I was able to continue caring for my family, including my elderly parents who came to live with me. So, for that, I'm really grateful that I was able to do that. But I was also just really aware that there were a lot of people where disparities and inequities were even more, became even deeper. And so that was something that was able, we were able to bring into the classroom, but to prepare future public health professionals. From the research perspective, as Paul mentioned, there was actually an opportunity. So I've worked with STI prevention on college campuses, so that's my closest sort of, work with infectious disease. But we had a request from Dr. Deborah Birx through the governor's office to work on some incubation, some rapid, research work to see if they could reduce the quarantine times on a national level, and she went to Governor Burgum, and so I actually took on that project with Paul and Josh Wynn from UND, and so it wasn't really in my bailiwick, but as a result of that, just really worked more closely with Siri then on some other projects as well. But one of the things that really stands out to me in terms of the pandemic is the students who had graduated from health promotion or community health sciences, so not infectious disease, and they were working in local and state public health kinds of areas, and they were telling me about how their work pivoted, and so it was I think what it told me is that we're really preparing our students for public health for adapting, adaptation to, what the needs are. And they were being pulled from their programmatic areas and they were put into, areas where they were having to, do all the communication for the county level, COVID mitigation, efforts and things like that. So that was really interesting to me, is to hear back from our graduates and how their work was pivoting and how they felt really prepared for that. I asked them, how are you feeling about, that new role? And they're like, I'm ready. I'm up for it. So it was really gratifying to hear that.
Sure. And Andrea?
Yeah, I similarly in the classroom in terms of being able to pivot, because we're a distance education program, and being able to just adequately, efficiently, and effectively teach our students from our homes during those initial months, just to pivot to straight Zoom to online. It was amazing to see everybody come together. But on a personal note, it actually impacted me academically and personally. My husband is a high school teacher, and he struggled to move his class online. And I am close friends with many K through 12 teachers. And as a result of that, in those first few weeks of the pandemic, it actually allowed me to start a research project on the stress that the pandemic had on teachers and switching their classes to more of an online format. And we ended up doing a longitudinal study. It was 3 or 4 waves of surveys over the first 2 years of the pandemic. And additionally, my parents are over 70, or were over 70 when the pandemic started. And that allowed me to collaborate with other colleagues here at NDSU, then to study the impact of the pandemic and the mitigation efforts on the coping skills, mental health, loneliness related to these efforts on older adults. And so I actually kind of was on the front lines of studying this, and then helping my parents through the pandemic, and studying this and helping my husband and my teacher friends through the pandemic. And so it offered me kind of a window into these impacts of the pandemic. And so, yeah, it was eye-opening, to say the least.
Sure. Well, thanks for sharing. It's always that, I think it's kind of like an added benefit when your family members could be also part of your research cohort. One of the things that happened during the pandemic and with COVID and the evolution of the virus and the disease itself is that there could be, because of the rapid change in the knowledge that we have gained. But one thing that happened, and it is evident almost to everyone, and I want to start with Renee and Paul and their reaction to that, is that there has been we lost the trust from the public. Public used to kind of like have their trust in public health, in the health field, in the health professionals, and the whole pandemic and the massive amount of science and changes that happened, as well as a lot of the misinformation, resulted in this lack of trust. What do you see a way to restore this trust that we have lost from our citizens and residents?
You want to start, Renee?
You could, well, I was going to comment one thing on the prior question, and then I can go into this question. It's interesting to hear the different perspectives and the impacts of the work. One thing I wanted to be sure to mention is local public health and the frontline healthcare workers that were out there throughout the entire pandemic. There was not, or we didn't have an option to work from home. And so I think we were on the front lines throughout the entire pandemic, which we were tired. We're tired of going through. Everybody, had to work from home and had that opportunity, but we were on the front lines, and now we're continuing. There hasn't really been a break because it seems like there's always rolls from one thing to another, from COVID into the next public health type of crisis. So just want to mention that, but the transparency, I think, is key to restoring our trust in public health. I think there were some maybe mistakes made when we look back at some of the initial response efforts, and that happened, I think, at all levels, from federal, state, down to the local level. The issue of open communication and having that line of communication between all parties, I think, was hard, especially when everyone was so unsure of what COVID was at that time and what the impacts were going to be. Everybody was learning, and I think at the federal level, CDC really didn't want to provide information without being 100% sure that it was accurate, and they have to go through levels of review and all of that before putting out messaging. When the general public really just wanted to know, what am I supposed to do? How does this impact me? What is this disease going to do to me and my family? And so that delay in kind of reducing or releasing information, I think, was challenging for us at the local level, because we were the ones getting all the questions from the public. We were getting phone calls. People wanted to know and they wanted answers. And we were relying on the information we got from the CDC or from the state health department, which wasn't always timely. And so communication, I think, would be key to restoring some trust, and then just the transparency of reality. If we would have known in the beginning that the reason for, not allowing people to wear masks, and Dr. Carson, you're an expert when it comes to that and the masking and the studies that have been done, was because there really wasn't a supply for the general public. People maybe would have understood that a little bit more, and we would have not had such a pushback when that was implemented. So, but feel free to chime in, Dr. Carson.
Yeah, Dr. Wehbi, this is something I think a lot about now, and this is the, our effectiveness in implementing public health interventions around COVID was seriously hampered by, the growing mistrust, the misinformation, disinformation, and trying to kind of put fingers in the dike once that was happening is really not very effective. And so, taking that public health perspective, we're asking a lot of questions like, what do we need to do upstream to not get to that sort of place in the first place? I think to your immediate question is I think it's going to be a hard job rebuilding trust. I think it's going to be years trying to rebuild trust. And I think it's a really important thing. And I think that starts with being sort of radically and brutally transparent on what we know and what we don't know. So I think, maybe nobly or understandably, public health people at the beginning of the pandemic spoke with more sort of certainty than we had a right to. And I'll put myself in that same boat in order to try and get people to wear masks or take vaccines or so on, when we really should have been saying all along, this is what we have as the state of science right now. This is likely to change as we learn more. One of the kind of memes you see out there on social media is, look at them, the science changed. The science, almost in a sneering, mocking way, the science changed. Well, the scientific method didn't change. The approach that science takes didn't change, but the information, as we applied it in real time, as we gained more knowledge and applied it to more populations, more studies, did change. And we need to really inoculate, if you will, the population that that's the nature of science. It's messy and it slowly advances towards truth. That's what to expect. And certainly when there's a new thing like a pandemic. I think we also in public health have to take kind of a hard look at how we do things. A number of us heard Peter Sandman. He's an expert on risk communication. He spoke to the Association of State and Territorial Health Organization a little while back, saying kind of what he thinks we could have done a lot better. And one of the things he talked about was that overconfidence to proclaim, and failure to proclaim uncertainty. prioritizing health over all other things. You know, we live in public health. We think it's super important. We, you know, maybe we think it's the most important thing, but it's not the only thing. There are competing values there. You know, the one that we heard a lot of is lives versus livelihoods, you know, and so we're not the only seat at the table. There are other that are legitimate things that are the community puts its values out there, of which one is public health, a very, very important one, but not the only one. I think, you know, addressing misinformation with empathy and credible messages. I think it was easy to be sort of dismissive and maybe even, you know, looking down on kind of that misinformation, but trying to understand where that came from. And that usually comes at a time where people feel powerless, and they're confused, and there's conflicting voices, and approaching that with empathy, I think, is really important. And then the last thing I would just say is I think we need to get a lot better at how we communicate science. I think we need to understand that the basic level of sort of science and mathematical literacy of most people, and this isn't speaking down in any way, but it's, you know, we talk about things like relative risk and vaccine efficacy and, you know, percentages and numbers and confidence intervals and so on. And that's just like unintelligible to most of the population. And so trying to be able to figure out how to communicate risk benefit types of decisions in a way that's very immediately graspable by the general public, we need to get much better at. And I don't think we're very good at it. And I think we need to do that. And the last point I would make is I think we should be just assiduous about trying to not fall into any politicization. And that's not always possible because policies often are taken up by political parties and promoted or adopted by certain political parties. But I think we have to be very stringent in trying to not give sway to, you know, politics whenever and however possible, so that we can remain credible to all parties. And then maybe leveraging our healthcare colleagues, because the one group that has maintained trust is doctors and nurses, your primary care doctor and nurses. And they're our partners. And I think one good thing that's come out of the pandemic is that we work much better with them than we ever have before. A lot of silos got broken down by the pandemic, which I think is a really good thing. And using them as credible voices more and more, I think, can be helpful.
Sure. Anything else to add, Alicia, or and then Terry?
Yeah, I wanted to add that I have a different perspective due to the position that I'm in compared to Renee and Dr. Carson. I had a chance, I think, to work more closely with community members. And so some of the community members that we worked with, I don't know that we need to use the word restore. I think for some of them, this actually increased their trust. And so when I'm thinking about this question, I'm thinking more along the lines of like, how can I now maintain that? Because during the pandemic, there was, you know, somewhat more flexible funding. We were able to be more responsive sometimes because we were just dedicating a lot of time to some of these specific communities. And right there, I remember making phone calls to individuals and saying, what's going on in your community? And all of a sudden we were there and we're present with them. And I think that trying to stay connected to the community and recognizing that for the communities that we're working with through the community engagement unit, things are still really urgent. There's huge urgency around the problems they're facing. And so during that time when things were urgent with COVID, we were right there. What can we do? And even though we couldn't necessarily do a lot, I feel like they had a sense that we were present with them and trying to figure it out. And so I hope, for me, I'm thinking about trying to maintain that trust that we may have gotten in some of those communities and making sure that we stay present and that we don't pull back, and that we still come to their table and see what's going on with them, even if there's nothing that we really necessarily can offer. I don't have a big check in my back pocket, or I'm never going to have that big check in the back pocket. And even when I don't need information from them, to just be there and say we're still here. So that's kind of where I'm thinking about for our community engagement unit, is making sure we're still keeping that same sense of urgency, same connection, and being present.
Dr. Wehbi, if I can just, Crystal and one of our students asked, I think some interesting comments and questions, and she asked the question sort of maybe a little bit the other side again of what Dr. Belay just said. She's kind of questioning whether public health ever had that trust, because was it ever very visible and known in a way to the general public like it was during the pandemic? And I'd say probably not. I mean, it was sort of a hidden, kind of behind the scenes entity. She also, brings up the question about, for the first time, here's this government, here we are, government, we want to help you, telling people what they could and couldn't do, which I think also brings up the issue of mandates. And mandates really charged up a large segment of the population in a very negative way towards public health. And it struck me that is a tool that can be effective, but it's a blunt force instrument that should be wielded very, very cautiously, and whenever possible, in my opinion, very selectively. I think that's one of the biggest things that really kind of turned people to not trusting or being very suspicious about public health.
Sure. Terry, go ahead.
Yeah, I think that going back to what Alicia said, how do we build trust and respect? I think if we think about how do we build trust and respect, whether we're in public health or not, there is an equation. The equation is trust and respect equals time and relationships. And it takes time. And I don't think that we as public health, if we really want to engage a community and to build trust and respect, that we spend the kind of time that it takes in that community to develop those relationships. I kind of learned that in our years in Africa doing community engagement, even though I was from a different culture. If I spent time with people, sitting down and having a meal with them, which is so important in almost all communities in North Dakota, not necessarily just there to sell a project to them, but to say, I'm interested in you. I'm concerned about you. We may have different approaches here, but I'm here for you. I think that's how you develop trust and relationships. And I think that relates to the whole concept of advocacy, true community engagement, where you're dealing with what we call vertical communicators, which are the formal leaders, the informal leaders, which are the horizontal communicators. All across the board, it's related to relationships. But then I wanted to mention one other thing, thinking about the future. One of the things that Dr. Richard Riegelman from George Washington University mentioned is it gets back to the misinformation. Part of the problem with misinformation is that most people, even graduates of non-scientific disciplines, don't have the tools that they need to evaluate information that they see in the media. And one of the things Dr. Riegelman suggested is that every discipline, undergraduate discipline, should have basic epidemiology to understand how to evaluate information that they're receiving. And he pushes that. I know I was with him and I've known him for years, but I was up at UND and he spoke at UND and was pushing that to include that with other disciplines. So I think looking at the future, we could look at the way we train our students in the United States so they can better evaluate misinformation and validate it.
Sure.
Yeah, I just point out to that point here, I totally agree. Couldn't agree more. And we're applying some of our grant work now towards developing that curriculum on campus and asking those educators to bring it down to the high school and middle school level. And there's some evidence that actually can really work, that when you do that kind of training, even at like the 8th grade level, 8th graders can get pretty good at sort of sifting through what's a valid versus an invalid kind of empiric claim, particularly in the realm of health. So I couldn't agree with you more.
So thanks for all the insight. I want to kind of wrap up with kind of like looking into the future of public health and what would be the greatest challenge? And that's kind of like in one sentence, and we'll go around all the panelists in one sentence or kind of couple items that you see would be the greatest challenge to public health in North Dakota. And maybe we'll start with Mary and Andrea, and then we'll move.
Well, I'm going to say something that's probably going to make the hair on the back of Paul's neck stand up. But I do have a few students, previous students in the audience who took promoting health through policy, systems, and environment. And I would say health is, and they know the response, it's political. And whether we like it or not, we have political forces at the local, state, and federal level that impact our health. And it could be policies that are related to health, or it could be policies that are related to economics, or anywhere in between. But I think the greatest challenge for challenges facing North Dakota in becoming the healthiest state in the nation, where all North Dakotans are flourishing, may be summed up as really influencing, as the knowledge and science brokers, the political will to do the things that create the conditions for all people to be healthy.
Sure. Andrea?
Yeah, so specifically for North Dakota, I think one of the biggest challenges is making or communicating to people, to making them understand that their behaviors and their decisions impact others, so that decisions that they make don't always just impact their own health, but the health of others. And I think for North Dakota, that might be one of the biggest challenges.
Sure. Renee, any thoughts on the biggest challenge?
I think the biggest challenge for us is moving forward is going to be workforce. And I know that's probably all of healthcare. People that have been in public health for a long time, we're seeing a lot of turnover. I think the pandemic had some impact on that with people that have retired or maybe been woken up to a different career during that time period and looking for something different or change. And so moving forward, we really have to make sure we have some of those bases covered. And I think there's some great partners, obviously, on the panel today that have students that are working towards public health degrees. And so that will be key to keeping us moving forward for public health.
Sure. And Dr. Carson, any major challenge you see?
I would go back to that rebuilding trust and finding the right messengers who use evidence-based communication strategies to deliver our public health messages.
Sure. Alicia?
Yeah, I agree with what all the challenges that have been stated, but I think one that I think about is during COVID, we saw vividly that cross-sector partnership, collective action, upstream work was going to be needed in public health. And I think our funding streams aren't aligned with that, and being innovative in how we kind of braid and layer funding and how we work together. I think that's going to be one of our challenges, because we're not really set up to have that kind of collaboration across all of the different sectors and funding.
Sure, thanks. And Terry, what's the greatest challenge you see?
Yeah, well, I think it goes back to some of the things that others have already said. I think increasing the advocacy, our tools to be appropriate advocates. And I think we oftentimes think of advocacy as being confrontational, and that's the most visible thing. But I think the major tool, and this gets back to relationships again, is around non-confrontational advocacy, and not just with the choir. You know, we oftentimes advocate with people that already believe the way we do. We need to engage with opponents, and with the goal of using our advocacy to influence them, whether it be policymakers or other groups that don't agree with us. That's one. The second one, I think, comes back to, I know what Alicia focuses on, is we really need to engage communities and develop the skills and competencies in our public health workforce to do that. And we haven't done that real well yet, because from my perspective, what we have done in the name of community engagement in the United States is usually community coercion. And that's where, you know, an external expert looks at the data, they analyze the data, they know what needs to be done, they go off and apply for a grant. When they get the grant and they get the funding, then they enter the community and try to sell it to the community. Obviously, that's the way most of our grants are. They're project oriented rather than process oriented, problem solving oriented. And if we keep doing that, we are going to have a difficult time truly engaging a community to own their problems and solutions. We just need to develop more of those true community engagement competencies and skills.
Sure. Well, I see kind of here a list of challenges that were shared with everyone. So I think we all know what will be the thrust of the work for the next few years, whether it is funding, workforce, building trust, engaging communities, the political will, advocacy. It's all a list of challenges that we have to start tackling in order to move forward with public health and eventually becoming the healthiest state in the nation. Panel, I like to thank you very much, Renee, Terry, Alicia, Mary, Paul, and Andrea. Thank you very much for sharing your expertise and knowledge. And I'll, Ramona, I don't know whether you have any parting notes or anything, but thank you very much for our attendees. And I'll turn it over to Ramona if she has any reminders for us.
Yes, I echo the thank you to all of our panelists, a really thought-provoking and also inspiring panel. Hopefully, Dr. Wehbi can take some notes too for his work as our state health officer. And again, a big thank you to you for moderating this panel. So thank you to all our attendees, and we will have a recording of this posted. And here are some other ways to be able to follow NDSU Department of Public Health online, and we will be sharing more information about our seminar series for the next academic year as we get closer to September. So thank you all.